Hello, everybody. Welcome to Ophthalmology Mastery Clinical Skills for MBBS students. In this video, we'll learn about the examination of a case of lid swelling. Most often, a chalazion is kept for you, so that's what we will see in this video. What are the salient features you have to ask? What are the salient features you have to present? And how do you manage? And what are the common questions asked during the case of chalazion? So usually history you will have to ask the presenting complaint will be painless swelling, patient presents with a painless swelling in the upper or lower eyelid since few days or few months. Okay, most often it's few days. Then the history of presenting illness would be patient noticed a swelling in the if in this picture we'll say patient noticed a swelling in the left lower eyelid since 2 weeks. The swelling was small in size to begin with and has gradually increased to the size of a peanut at present. There is no associated pain or discharge. You have to ask pain to rule out, even if the patient does not give you pain, history of pain, you have to ask to rule out yeah, suppurative conditions like internal hordeolum or external hordeolum. Not associated with blurring. These are negative history you have to ask, not associated with blurring of vision. Why large chalazions can cause astigmatism and reduce the vision for the patient. Most often they present with cosmetic disfigurement, so you that's what the patient will present with. And you are also going to ask not associated with itching or eye rubbing because itching and eye rubbing, constant itching and eye rubbing can lead to chalazion. Okay, so or uncorrected refractive errors where the patient keeps rubbing the eye can lead to chalazion. Ophthalmic history will again ask for any history of using spectacles or any drops used for allergic conjunctivitis. Again, both these conditions cause eye rubbing and which can predispose to formation of chalazion. The next thing that you would ask is on examination you would do is examine the visual acuity. Though it's a lid swelling, you have to still examine the visual acuity and present the visual acuity, the distant visual acuity, and pinhole is a must because if there is an uncorrected refractive error, you will be able to identify it in your case. Lids, how will you present any swelling? You will say the size, 1 by 1 centimeter in size, spherical or oval shaped swelling seen in the lower lid at the location medial 1/3 and lateral 2/3 junction, or the central or the lateral 1/3 area of the lower lid or upper lid. So you have to present the location, the shape, and the size. Then inspection skin over the swelling is smooth. Okay, and the not only the skin, you also have to examine on the conjunctival side. Conjunctival side of the lesion shows mild congestion or a gray pointing is seen. And on palpation, the swelling is firm to palpate and non-tender. You have to present these findings, and only then you'll be able to come to a diagnosis of chalazion. So you will say eye, which eye, right eye or left eye. Please remember, before going to the diagnosis, you will complete the whole examination. After visual acuity, the lids, you'll complete all the conjunctiva, cornea, and antechamber, iris, pupil, lens, okay, and digital tonometry. Unless the examiner says go on to the diagnosis, you will not stop. You will complete both the right eye and the left eye. Then finally, the diagnosis will be right eye or left eye, lid, upper or lower lid location, and you will present it as right eye lower lid chalazion involving the central 1/3 of the lid. Okay, so that's how you present. Wherever is the location, you will present that. What are the common questions asked during chalazion? What is chalazion? If you say chalazion, they will definitely ask you what is chalazion. So you have to know it's a chronic, non-infective granulomatous inflammation of the meibomian glands. What is the etiology of chalazion? So usually most often the risk factors predisposing are repeated eye rubbing and blockade of the meibomian openings, and the pathogenesis is a granulomatous inflammation of the meibomian glands. Okay, then what are the complications of chalazion? What will happen if you leave it untreated? Large chalazions can cause astigmatism by pressing on the cornea. Secondary infection can result in internal hordeolum. Sometimes malignant transformation can happen, and since it is arising from meibomian gland, you will have sebaceous gland carcinoma. It's a very rare complication, but can happen. Now, what is the treatment of chalazion? This is a definite question that will be asked. So you have to know when you write your management also you will write this. Okay, conservative management, hot fermentation and antibiotics like azithromycin are given. Intralesional triamcinolone can be tried for smaller chalazions. But what are the side effects of intralesional triamcinolone? You have to know it can cause depigmentation. So it is not preferred in dark skin individuals like Indians. Okay, and the definitive treatment is incision and curettage. Please remember it is curettage because it is sebaceous gland accumulation. It's not an infective suppuration of the gland. It is accumulation of the secretion. So you have to incise and curate out the content. So it is incision and curettage. Okay, what are the next question that would be asked is what are the describe the steps of incision and curettage. So basically first you have to put topical paracaine to anesthetize the conjunctiva and then infiltration of the lid around the swelling. You have to infiltrate the lid around the swelling with 2% lignocaine. Then a Chalazion clamp is applied with the ring on the conjunctival side and the solid plate on the skin side. Why? What is the use of a Chalazion clamp might be asked to localize the lesion and to achieve hemostasis. Then the next thing is an incision is made. If it is on the conjunctival side, we make a vertical incision. If we put on the skin side, we make an horizontal incision. Why? Again the question will be asked, why do you put a vertical incision? So basically to avoid damage to the neighboring meibomian glands. So if you see here, all these glands are vertically arranged, right? So if you put a horizontal incision like this, then you will damage the adjacent normal meibomian glands. You don't want that to happen. So that's why you will put vertical incision. So only that particular gland which is involved can be curated out. Whereas when you put on the skin side, you don't want to put a vertical incision because your Langerhans lines as, uh, are present horizontally. So when if you put a horizontal incision, the healing is better and the scarring is minimal. Okay, then horizontal incision to minimize the scarring. Curettage until you use a Chalazion scoop and you curettage until you feel a gritty sensation, right? That's a treatment of Chalazion. Now, other questions is what is internal hordeolum? How do you differentiate Chalazion from internal hordeolum? Internal hordeolum is a suppurative inflammation of the meibomian gland, whereas Chalazion is a chronic granulomatous non-infective inflammation of the meibomian glands. That's why antibiotics are not the mainstay of treatment for Chalazion, but antibiotics are the mainstay of treatment for internal hordeolum. How do they present? Unlike Chalazion, which is painless, here they are acute onset, painful red swelling of the lid. Okay, so and they present very early. They don't wait for weeks or days before they present. They present immediately one day within a day. How do you treat? You treat medical management with antibiotics, analgesics, hot fermentation, and surgical management. You have to remember it is incision and drainage, not curettage. Here, as soon as you put an incision, pus will pour out because it's a suppurative inflammation of the meibomian gland. Okay. So, what is external hordeolum? External hordeolum is suppurative inflammation of the Zeiss gland, which is present along with the anterior margin of the eyelid, along with the eyelashes. How do they present? Again, they present acute onset painful red swelling of the lid, but the pointing is outwards. How do you treat? Again, the same similar management as in internal hordeolum: antibiotics, analgesics, and hot fermentation. Surgical management is incision and drainage, if it is, because it is suppurative, right? So how will you? The other common question is how will you manage recurrent chalazion? Okay. So the first thing you have to say is if a patient has recurrent chalazion, one, you have to rule out sebaceous gland carcinoma because elderly patient presenting with repeated chalazion and has undergone many surgeries like incision curettage but keeps coming back with this lesion in the same area, then you have to rule out sebaceous gland carcinoma in these patients. In younger individuals, probably meibomian gland dysfunction. You have to treat that and then manage the recurrent chalazion. So these are the common questions asked in Chalazion. You have to know that you have to describe the lesion properly. The history has to be presented, describe the lesion, inspection and palpation, come to a diagnosis, and you have to write the management for a Chalazion. Thank you very much.